Through this video illustration, we present our experience of utility and versatility of fluorescence-guided surgery with an emphasis on distal mucosal margin tattooing in rectal cancer. A 58-year-old lady with mid to lower rectal cancer, post-neoadjuvant chemoradiation and a residual T3N2 growth is planned for laparoscopic ultra-low anterior resection under fluorescence guidance. The procedure begins with the assistant providing a 2-point traction on the rectosigmoid and sigmoid colon. Following this, the right pararectal fold is incised and the dissection continues in a craniocaudal direction along the course of the inferior mesenteric artery while safeguarding the autonomic nerves. The sigmoid colon is mobilized in a medial to lateral direction in a complete mesocolic plane by sharp dissection. Care is taken to safeguard the left ureter during this dissection. The inferior mesenteric artery is dissected at its origin and its tributaries, namely the left colic and sigmoidal branches, are delineated. All the lymph nodes and fibrofatty tissue from the root of inferior mesenteric artery to the origin of the left colic artery are cleared for an optimal D3 lymphadenectomy. High ligation of the inferior mesenteric artery is performed after intersheath separation technique to safeguard the autonomic nerve plexus. The descending and sigmoid colon is further mobilized in a medial to lateral direction in a complete mesocolic plane. The line of Tolts is incised and the dissection continues in a cranial direction to achieve complete splenic flexure mobilization by dividing the splenocolic, phrenincocolic, pancreaticocolic, and finally the gastrocolic ligaments. During presacral TME phase, the dissection continues between the visceral and parietal peritoneum to have a good composite pathological parameter. The rectum is mobilized circumferentially along the TME plane. The pelvic phase is grouped into 6 phases. The posterior presacral TME, right anterolateral mobilization, right posterolateral mobilization, left anterolateral, left posterolateral, anterior dissection along the rectovaginal septum, and finally the deep pelvic phase. It is an effective practice to complete right anterolateral mobilization before left anterolateral to prevent rotation of the rectum in an anti-clockwise direction, which hinders dissection along the right anterolateral side. Care should be taken to selectively divide the rectal branches of autonomic nerves without risking injury to the main trunk. We can appreciate the course of the hypogastric nerve along the pelvic wall. The assistant retracts the rectum in a cranial direction to facilitate anterior dissection. The denonvillous fascia can be appreciated here. The plane of dissection is posterior to the denonvillous fascia along the rectovaginal septum. Dissection continues until the bare area of the rectum, which is devoid of mesorectum, is reached. Reflection of the endopelvic fascia can be appreciated, and the rectum is circumferentially mobilized with utmost care without causing any inadvertent injury to the rectal wall. It is imperative to divide the hiatal ligament and mobilize the rectum up to the pubic floor until the pubococcygeus is appreciated. This facilitates stapler division of the rectum with ease. Intraoperatively, under proctoscopic guidance, an accurate and precise 2 cm distal mucosal margin is tattooed with 1 ml of reconstituted indocyanine green. Following this, an endo-GI stapler is used to divide the distal rectum. pelvis with preserved autonomic nerves can be appreciated here. The specimen is exteriorized through a utility incision in the left iliac fossa. Proximal point of transection is determined under fluorescence guidance. An anvil is placed and secured with a pursing suture. We can appreciate the staple line at the level of the pelvic floor. A mechanical double-stapled end-to-end coloanal anastomosis is performed, following which perfusion is rechecked. Air leak test is performed. A pelvic drain is placed, and we can appreciate an adequate length of bowel reaching up to the pelvic floor without any traction on the anastomosis. Final histopathology showed a moderately differentiated adenocarcinoma PT2N2, distal resection margin of 2 cm and a circumferential resection margin of 5 mm. The duration of surgery was 250 minutes with a blood loss of 110 ml. Patient was compliant with the ERAS protocol during the postoperative time and was discharged on day 5 with stoma care education. Distal mucosal margin tattooing is a simple reproducible technique where ICG serves as the GPS for achieving an adequate margin.